Good afternoon. Welcome to our talk on socialism. You're in lesson 13, only one more to go after today. I hope you're all doing well at home. We're continuing on in our discussion of socialism, looking at kind of some of the practical issues now of how this is applied. Perhaps the most contentious area of kind of current discourse with respect to socialism is the area of healthcare. And I will tell you that, first of all, I'm not a healthcare economist, and I'm certainly not a healthcare expert. But I think we can apply together some economic tools and way of thinking in application to the healthcare issue, as well as cover some basic definitional things that can give you a framework. Obviously, in a 1 hour course, we're not going to be able to go into a lot of depth on everything. We spent a lot of depth in the first part of the course going over the economics of it. This area on healthcare, we're just going to necessarily skim the surface. But I think we can capture some of those essential areas for you to be aware of, and you can ask yourself questions about it and learn more from this point forward. So what we're going to do today is focus, well, we might, by first thinking about you asking a series of questions that you ought to be thinking about. This first one, you often hear this in the public discourse. It's almost meant to be a rhetorical question. Is healthcare a right or is it a privilege? When, of course, we don't want healthcare to be a privilege in the sense that we want only rich people to be given something, for instance. So then necessarily don't we think it needs to be a right? But, you know, then is that even the right question we have to ask? And I would assert to you that perhaps you need to ask, is this a false dichotomy in our public discussion? Is it necessarily one of these two categories, or is it something else? That's something you should be asking as you go through this. And when you start thinking about this, you need to apply the same logic. In general, a good way of trying to think about things is whatever logic you approach for one thing, what would a consistent application of that argument be applied to something else? So if we say, for instance, we need healthcare to be able to live, therefore we must have this as a right. Well, you can start to think of any number of goods and services that you need to live. I mean, obviously food, housing, but community, companionship. Is this a right then that someone else is responsible to give to you? And what would that look like? And why would that be a right? And so we could go a step further. If it is a right, what does that even mean to say something's a right? What's implied when we say something's a right? Who's responsible to secure that right for you? And under what moral basis is there a claim to that right? We're going to see in a moment the right implies obligations. Well, how can you assert that? That's something we have to ask ourselves. We also need to understand, you know, what level of right. There isn't some 1-0 on-off switch with respect to healthcare. It's entirely one question to say, should someone have access if they're in a serious accident where their limb is bleeding to go to an emergency room, and therefore that they should have access to that whether they can afford to pay for it or not. It's entirely another thing to say whether someone should have a right to, say, elective surgery. What about plastic surgery, for instance? These are the kinds of questions that we would want to ask. And once you start asking about that right, does this allow some people to go above and beyond whatever this healthiness is, you know, whatever this minimum level of right is? Are we comfortable with allowing some people to consume a level higher than whatever this minimal level of right is? Why or why not? These are questions we have to ask. One of the things that we'll often hear conflated, and you need to be asking yourself this question, is do we necessarily have health care if we have health insurance? Because this is often discussed. We assert that because X percentage of people in the United States do not have health insurance, that they have no access to health care. Well, that's patently not true. People can go to the doctor. If they don't have health insurance, they just have to pay out of pocket. What does that look like? And why do those people look at it? You also have to look at some of the rationale and reasons. In some cases, because they can't afford it. In other cases, for instance, young people often will forego health insurance because they're young. They figure they're healthy. Maybe they don't want to pay that cost. These are all kinds of things you want to think about. Then you have to ask, is there a balance that we should have between the social responsibility, even if we agree that there's some right? How do we ensure that there's some sort of personal responsibility for someone's health care? And how do we strike that balance? For instance, I know someone that I tried to kind of mentor and encourage to engage in healthy behaviors that does not have very much funding, is very limited, often does not have funding for medical issues. Yet this individual is a significant chain smoker, has been for years, is significantly overweight, which those are contributory factors towards those healthcare costs. How do you balance those kind of behavioral things that lead to health implications and other social responsibilities? These are all part of the questions as well. And then finally, obviously, we want to ask ourselves the question, what does a biblical worldview bring to this issue? You'll notice that I have on the bottom a quote from the author of our text, Conflict of Visions. The first law of economics is scarcity. The first law of politics is to ignore the first law of economics. We're going to see that plays into this question as well. The reality is that healthcare is an economic good just like others. It's a scarce resource, which means there's not enough freely available from nature to go around at zero price. In other words, it costs money to produce it. You have to sacrifice something to gain health care. And so the first law of politics tries to ignore the reality of scarcity in this. And you see many of the discussion items or proposals that we see try to mitigate the fact that there is a necessary scarcity in healthcare. But we'll cover that as we go through. So hopefully these kinds of questions, and these are questions for you to reflect on beyond the scope of the charts that I'm going to show you today. But this is, I will have a lot of charts which will be helpful to inform you towards some of these questions. And I want to start off with the Good Samaritan from Luke 10:25 through 37. I'll go ahead and build it. This is very familiar. You're all well aware of this. But I think it's important to set the stage for how we might think about what our Christian responsibilities are towards others that don't have health care. I'll go ahead and read it. And behold, a lawyer stood up to put him to the test, saying, Teacher, what shall I do to inherit eternal life? He said to him, What is written in the law? How do you read it? And he answered, You shall love the Lord your God with all your heart and with all your soul and with all your strength and with all your mind, and your neighbor as yourself. And he said to him, You have answered correctly. Do this, and you will live. But he, desiring to justify himself, said to Jesus, And who is my neighbor? Jesus replied, A man was going down from Jerusalem to Jericho, and he fell among robbers, who stripped him and beat him and departed, leaving him half dead. Now by chance a priest was going down that road, and when he saw him, he passed by on the other side. So likewise a Levite, when he came to the place and saw him, passed by on the other side. But a Samaritan, as he journeyed, came to where he was, and when he saw him, he had compassion. He went to him and bound up his wounds, pouring on oil and wine. Then he set him on his own animal and brought him to an inn and took care of him. And the next day he took out 2 denarii and gave him to the innkeeper, saying, Take care of him, and whatever more you spend, I will repay you when I come back. Which of these 3 do you think proved to be a neighbor to the man who fell among the robbers? He said, The one who showed him mercy. And Jesus said to him, You go and do likewise. Now, this parable is clearly about trying to help us understand the limits of who is our neighbor. And what we see from this parable is clearly everybody, even those we are most likely to despise. You're well familiar. This was a Samaritan who was not popular amongst the Pharisees, as Samaritans had caused immense problems for the Israelites and were considered half-breeds and all this because they intermarried with pagan nations as well. And so those that were very despised in that culture were found to be the neighbors. That's kind of a limit to us. Even those we don't like or think may have problems or even contributed towards their issue, they are our neighbors. But then we can ask ourselves the question this: did the victim of the robbers have a right to be helped by the priest and Levite? Now, first off, when we start to think about this, clearly we would think to have a negative idea of the priest and Levite. I mean, after all, the very positions, priest and Levite, we would expect that if anybody, they should come to the aid. And yet, the man that had been beaten there were still potentially robbers out there. They could have attacked the priest and the Levite as well in their own concern for their safety. They might have not had cause to think that they themselves might be attacked as well. So, we might not say that they have a right in the sense, or he might not have a right in the sense to demand that. And we see something analogous today in our own culture. We have two kinds of laws. We have Good Samaritan laws, which kind of protect people that come alongside an accident and they help. And Good Samaritan laws are supposed to prevent, like, the person you're helping from suing you from helping them. Like if something bad, if you move somebody out of a car and that causes their spine to break and they're paralyzed forever, they can't sue you because you had no intention. You're just trying to help them, pull them away from a burning wreck. That's kind of the Good Samaritan laws. The flip side of that is these duty to rescue laws. We have very few of them. There are limited, and we have some in our culture, but they're rarely formalized with legal sanctions if action is not taken. And in most cases, the common law in the English-speaking countries that use the common law kind of practice, they don't require us to come to the aid of another. That doesn't mean there isn't a moral requirement, a moral claim that should be satisfied. But here's kind of the interesting thing about this. It does transfer this question to a question of mercy rather than justice. And that's really important because clearly the care that was needed and that the Samaritan subsequently gave was in excess of what would be considered by justice. I mean, to the extent we do have a duty to rescue laws, the minimum kind of thing that we're required to in general, like if we were the Levite in that case or the priest, is we would at least be obligated in many states, not all, there's some deviation here, but in general, we would be required to kind of notify authorities, hey, there's this guy on the side of the road who's bleeding, and when we get to the next town or something like that, that would be. But so in this case, the Samaritan did more than just notify authorities. He didn't even just put him on his beast of burden, take him into town and drop him off for the, quote, authorities to take care of him. He gave out of his own self. He suffered personal financial consequences in love of neighbor. And that's kind of the story there that we want to consider. He acted out of mercy. Notice what the lawyer had said at the end. He couldn't even bring himself to say the name when Jesus asked who proved to be his neighbor. He said, the one who showed him mercy. And then Jesus said to him, you go and do likewise. We're going to see that that's a big difference whether an action that is morally obligated is taken out of mercy and compassion. And we saw in the parable that the Samaritan did have compassion for this hurt man, rather than something that is a matter of justice and as a right. But let's move on. Okay, I think it's also useful to talk about how healthcare economics works. Again, you don't have to be a healthcare economist to kind of look at these basic facets. First of all, healthcare is an economic good. And what I mean by that is because it's an economic good, there's not enough freely available from nature to go around. I mean, you've got to train somebody to be a doctor, to be a nurse, etc. And those doctors and nurses could be doing something else. There is an opportunity cost to their time. So it means there's going to be a rationing effect of this. Because to choose healthcare necessarily means we're not going to choose something else that could be delivered by society. This is just very fundamentals of economics. There is going to be rationing of healthcare. And then the question becomes, if it's not rationed by the market using the price mechanism, then you're going to have rationing by some other force. It could be by the political process, determining who gets the critical care. It could be just by queuing, waiting. That's another form of rationing. Sometimes at a concert sales, you might not have a different price for concerts. You'll just wait in line, and whoever has the lowest value of their time will actually end up getting the good in that case. But there's always rationing necessary when we have an economic good. And that facet of the very nature of what healthcare is will not change depending on who is providing that, whether the government or the private sector. It just means instead of rationing by the price system, you're going to have to ration by some other process. If you have the government do it, it will be done by the political process. So I would assert there's no magic solution in a fallen world. Another key factor for healthcare issues is just in general across any good. And again, I've already asserted that healthcare is a good. Economic efficiency is best attained where the person getting the benefit of a good or service pays the cost. And what that means is if you're getting benefit from a good but you don't pay the cost, you'll have a high incentive to pay to consume a lot more than you need. And likewise, if you are paying the cost but not getting any of the benefit, you're going to do everything you can to avoid paying that cost. And so we see either an under provision or an overconsumption depending on where this burden is going to lie when you separate the consumption from the payment of the good. And that's across all goods. And yet in healthcare itself, we see that we've fundamentally distorted that connection between who receives the benefit of healthcare from who pays the cost. All of our healthcare insurance schemes are generally about shifting who pays the cost. When I often get, and you may be likewise, or your families may be likewise. I'm offered, for instance, at my work, and many work institutions have not only healthcare, but they have other things you can pay a certain amount of copay at your work for, say, vision pay, vision care, or dental care, things like that. And the first thing most of us do is we look at okay, how much is this going to cost if I sign up? What does it give? What are those benefits? And we quickly do the math. We have some sort of expectation in what dental fees are going to cost our family for a year. And then, okay, are the premiums that we're going to pay towards this insurance less than that amount? It's all about cost shifting. Who's going to pay the cost? Well, that's not about really aligning it to try to get an efficient outcome. What if instead I pay fully all the costs of my my dental care, and I get all of the benefit, which naturally if I'm going to get whatever benefit from dental care, I'm going to get it for myself, then we're likely to get an efficient outcome because I'm only going to choose dental services if I believe the benefit exceeds the cost. That is not the case when someone else is paying for it. And if I determine that it's a good deal for someone else to pay, like buying dental insurance, because I think I'm going to consume more of that, I'm going to have a temptation to overconsume that particular good. And that does lead to a lot of inefficiency in our system. We see that. So the other thing is it's really not even insurance. Insurance is all about pooling risk to help us avoid an unreasonable loss. Like, if you have all of you, not probably all, I would assume all of you, but may not be all of you, have a driver's license and you now drive your car, and many of you are paying for car insurance on your vehicle. And you're going to, when you go into that, you're pooling your risk. In other words, they're going to group you with people that have a like risk characteristics to you, and you're going to pay more. The reality is you all are undoubtedly paying more for your car insurance than I am because you're much more risky. And incidentally, we will have a chart on that just a little bit later. But what it is we're going to pay in according to trying to keep you from suffering unacceptable financial loss. So, for instance, if you have an older car, you probably should not be running what we call collision insurance on your car because it's a very old car and they're going to total out and you're not going to get much money anyway. Instead, you must have liability coverage, because if you cause somebody to die in an accident, God forbid, and you're sued, they can get many thousands of dollars, money that you do not have, and force you into bankruptcy. And so that's where insurance is trying to keep you from unacceptable loss. That's not what we do with healthcare. Healthcare insurance, we think, is to basically pay so we just consume everything. It'd be the analogous thing, going back to the car example, would be, hey, I'm going to pay my car insurance for wrecks, and it's also going to cover me to go down to Jiffy Lube and change my oil. We wouldn't think about that with other forms of insurance. It would be simply costly because nobody's going to subsidize my Jiffy Lube consumption in auto insurance. But that's not the case with respect to health insurance. There's tremendous mismanagement because of that. Okay, And so if we are able to, right now, primarily many of the systems we have, because we have a lot of private insurance, we're going to, if we shift the payment from the private insurance carriers to the government, the reality is we still have this third-party payment. We're still going to have a scarce good that must be rationed. It just means we're going to be angry at a different person when they don't approve and give us the service we want. Right now, people can sometimes get angry at their insurance provider for not approving a certain medical procedure that they feel is necessary. But it's not going to change if you go to a government system in the sense that it's now going to be more resource because it's just not there. It does lead to easier provision of a common minimal health coverage. We'll see that in a minute. But it doesn't necessarily mean that you're going to get more care overall or faster care, and we'll see some examples of that. Just as an aside, you may be curious, most economists would say, hey, the best way to treat this is just like regular insurance. So you should have some sort of catastrophic health insurance policy such that if you do get sick, or none of us could afford cancer, for instance. If you get cancer, God forbid, that's hundreds of thousands of dollars. We need to be insured against that. That's not a risk almost anybody, that most people I know at least, can afford. But if you need to go to the doctor for a flu shot, that's kind of like a regular expense. Why would you just not pay for that? You need to kind of treat that as an expense. And you can do that with health savings accounts where maybe you are allowed to put money in towards that you can apply towards those routine medical expenses. Another thing that would be helpful in there that many economists would say, certainly this one, is we should eliminate the tax break for non-monetary compensation, such as health care. What this does is gives us an incentive to have more health care because it's non-taxable. We're effectively subsidizing additional health care consumption, and that's one of the reasons why the U.S. pays so much more in health care. I'm going to go ahead and build this chart the whole way, and then we'll talk about it for just a second. We have, okay. We've talked about these differing reasons for socialism, and I've kind of grayed out the ones that are less applicable towards healthcare. But there's really a couple things that do apply. The inequality issue is front and center with healthcare. There's concern that, hey, rich have full access to the full range of health services, but poor, they're often left out. They may not have coverage at all. And so if we had a more equitable distribution of social resources, we could have the poor have actually increased access to health care. And it should be kind of a universal human right, as you see in the next bullet, that everybody should at least have some basic minimum. And another aspect you'll see is also in the control of it. You'll see some that are in favor of socialized health care. Hey, we need to make sure that we have just this minimum essential. We need production to go towards what's necessary, not what's frivolous. This might be exemplified by in the Affordable Care Act, which is also known as Obamacare. There was kind of a tax on so-called Cadillac plans. If you had, quote, excessive health care coverage, well, maybe we ought to tax you for that to try to kind of limit that. Because that puts too big a gap between the haves and the have-nots, so to speak. Another aspect of the control is we want to ensure coverage of politically desired health care. That was a big part of the debate. We want to ensure that every single person has access to the things that we care about most that happen to have political agendas associated with it. Abortion, reproductive services were just one of those. So those some of the reasons that we've been talking about before that are related to healthcare that we can think about. Okay, I wanted to have just a few minutes discussion about healthcare as a human right, because you'll often hear this asserted. The American Bar Association, they had their language. Just I'll let you look at it for just a second. Read that. Okay, as you read that long quote, basically asserting, hey, the rights to which we are entitled simply by virtue of our humanity, and I would certainly agree with that. But this is the next underline. Among all the rights to which we are entitled, healthcare may be the most intersectional and crucial. You're giving away when it says it's the most intersectional. Intersectionality is kind of the buzzword for the latest of progressive things. You can go off and Google and do your own search if you're not familiar with that concept. But that shows you where this organization is. They're very much taken the most progressive understanding of kind of rights talk that we have. They're not alone. The World Health Organization, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. And we can look on the political scene here in America. What's that look like? Well, Bernie Sanders. We say to the private health insurance companies, whether you like it or not, the United States will join every other major country on earth and guarantee health care to all people as a right. So Mr. Sanders thinks it's a right. Elizabeth Warren actually got her start in kind of the political sphere by examining bankruptcy and specifically with health care. Here's a quote from her. I've spent much of my career learning about families going broke from the high cost of health care. When I'm president of the United States, I'm going to do everything in my power to make sure that never happens to another person again. In her research in 2005, she is, among others, which I've got linked there, greater than 60% of bankruptcies are caused by health-related expenses, she asserts. I will tell you there's significant scholarly criticism of her work. Other scholars have said it's really more like less than 4%, because basically what she did was went out and looked at, did a sample of people that had declared bankruptcy and asked, had they had health care expenses that kind of was a factor in that? And if they said, yeah, then it said bankruptcy caused it. Well, undoubtedly with all of those people, there were a whole series of events which led them to declare bankruptcy, many, many expenses. The way she would have you lead to believe is, hey, you're otherwise healthy, everything goes well, and I get cancer, go in the hospital, I get a $200,000 bill, I have to declare bankruptcy. That's not typically what happens, and that's why some of these other lower numbers. In fact, one of the things that we often see in terms of the bankruptcy is the bigger issue is when people have negative healthcare outcomes, they have work and lifestyle changes. They may not be able to go back to work afterwards, whatever the debilitating illness or injury is. And that's a bigger factor than the healthcare costs per se. It's not that it's not there, but there's suffice it to say, there's a great deal of difference between 60% of all bankruptcies being caused by healthcare costs and 4%. But there is some research out there. AOC, what does she say? I blame us. I blame this body. She meant Congress. This was in a tweet she had. Because every single developed country in the world guarantees health care as a right except us, except in the United States, because we can't get it together. So there's a large contingent of organizations and people that think that health care itself is a human right. And almost all those people that talk about health care as a human right are making the close linkage that healthcare is synonymous with health insurance. That if you do not have health insurance, you do not have healthcare. Therefore, your human rights are being denied. That's not necessarily true, but that's kind of the background, the way people are thinking. That kind of leads us back to our book, Conflict of Visions. We didn't cover Chapter 8, Visions of Justice, last time. And just to set the stage before I get into this, because this chapter of Visions of Justice gets into rights talk a little bit, and is useful for us to think about this issue as healthcare being asserted as right. But just to refresh your memories about this, hopefully all of you are reading along on this book. For those that had the constrained vision, this constrained vision is very suspicious of individual knowledge, individual rationality as being anything close to the wisdom of the ages, the wisdom of the many. That the constrained vision thinks more along the lines of, hey, we basically live in a world of limitations and systemic processes that have emerged out of the interactions of many fallen individuals lead to the best outcome that we can do. Not that we need to stay in that outcome, but boy, changes are going to be marginal, small changes to that wisdom of the ages that would go forward. So that's the kind of the constrained vision. The unconstrained vision says, no, look, we are not limited fundamentally by some human condition. We just need elite leaders to kind of the vanguard to take us forward to where we need to go. And so articulated rationality, not some systemic processes, is really the solution. And what I mean by articulated rationality is some leader who can clearly speak and give us the reason and where we're going to tell us how to get there. So they have great faith, for instance, in the young people of the world to lead us to the future. So AOC would fit very well, for instance, the previous quote, with the unconstrained vision. They would be looking for someone like that who has a superior moral wisdom to take us forward. That would be kind of the unconstrained vision. The constrained vision places little hope in new ideas being in it is even the brightest, they would say, even the brightest ideas are just a drop in the bucket compared to the wisdom of the millions of people throughout the ages that have contributed to our overall social knowledge. So how does that apply to visions of justice? Let's look at it. So the unconstrained view. For the unconstrained view, rights flow out of justice. They're not something that should be traded off. In other words, we have a requirement to do justice, and do justice means we must give these rights. And these rights are not to be traded off. If you have a right, it's fundamental and intrinsic. Rights, they would say, trump interests. And so it meant to be a trump card. And it would work like this. Someone might say, I have a right to health care. You only have an interest in your own money. Therefore, my right trumps your interest. We can tax you to pay for my health care. That would be kind of the logic of this. My private property rights aren't really rights. They're just an interest. And so they're not going to be sacrosanct. They're to meet somebody else's fundamental human rights, my interests may have to be sacrificed. Godwin, who did the political justice book that was referenced in Conflict of Visions, he talks about this as the superior claims of justice. And furthermore, in their visions of justice, we want to find the individual justice because there's no two cases ever alike. We can't stand to have an injustice in any particular situation because, again, rights can't be traded off. And so we need to use the law to achieve the social results that we want to have take place. That's the way they would see this. And so rights are an outcome, not a process at this point. The constrained view is kind of almost the opposite of this. It's viewed in process terms. But when they talk about the rights that are given, it's seen not as benefiting the individual, but much more as what's necessary for the good of the social order. So any rights that we have are to help us all get along better. And so they would say that the social benefit of fixed law is more important than individual injustices. It's not that you wouldn't want to have individual justice. It may even be morally preferable to have this individualized justice. But it's just really not possible in the limited world we have to really get into the heart of man to know what the right solution is. And that's why we put kind of the framework in legal cases for decisions to be made. And here's a quote from the constrained view. The doctrine of the law then is this, that precedents and rules must be followed unless flatly absurd or unjust. For though their reason be not obvious at first view, yet we owe such deference to former times as not to suppose they acted wholly without consideration. This is very important. If you look at the logic of the constrained view, they're going to say that's wisdom of the ages. We don't know why, maybe we don't even know why this law is here, but there was a good reason why they came up with it. This is an expression of humility of our current understanding of the rationale of how we got there. This kind of idea would be totally repudiated by those with the unconstrained view. They would, in the unconstrained view, there's often this conflict between the way they see the oppressor versus the oppressed. And what was done in the past was just kind of this power differential led to the impression, and we must throw off this yoke. So the idea that we would, if we can't articulate the rationality of what this law is for this, it needs to be thrown out. So there's a much more willingness to throw away previous laws and decisions if we can't understand the impact. Whereas the constrained view will say, look, we may not know what they did, but there's some secondary consequences. People didn't just wake up in the morning and decide to make some unjust law. So that's kind of a conflict that they would have difference between the two. And so this is kind of the opposite on rights. So rights are guaranteed by an impartial process. For the constrained view, you're not necessarily going to be guaranteed some sort of equal outcome that you have at the unconstrained view. Again, kind of an opposite kind of view. And this leads to kind of the discussion of social justice. You won't find much, as Sowell notes, there's not much discussion amongst those people from the constrained view about social justice. They kind of ignore it as a category even. Um, Whereas on the unconstrained view, it's a high priority, whether it was called, and it's been called different names. Social justice was a term come up in the 18th century, but distributive justice, other kinds of political justice in Godwin's terms and so on. But nevertheless, social justice is where we start getting these arguments for more rights. And there's a reason why they call these things rights, because rights imply duties. If I have a right to someone, there's a corresponding duty somewhere else for some group or individual to ensure that I get that right. So that's why we often see some of the discussion talking about things being rights. And that really leads in. Sowell does not talk much in the terms of positive versus negative rights, but that's kind of what we're seeing here in the constrained versus the unconstrained view. The unconstrained view would be more of a negative rights, a right to be free from. I have right to life. You can't take my life, right? You can't. I have right to pursue. I have a right to pursue happiness. You don't. I'm not asserting that you have to provide me some pathway to happiness, but you can't put a roadblock up in the way of my pursuit of happiness. That's kind of the idea. It's more of a negative sense. Whereas the unconstrained view very much is a positive rights. I have a right to health care. I have a right to food. That means you have to provide me something, not just not deny me something, if you see the distinction. So they don't really talk about it in those terms, but that's essentially what's going on here when we talk about this difference in rights. Again, we're just doing a very fast-paced thing. You could find out a lot more about this on your own. This issue of rights is much larger than just healthcare, and it's much larger. You could have whole courses on this. Okay, now I'm going to go faster, fear not, for those that saw the number of slides, because I do want to kind of cover kind of the U.S. healthcare system. And I got a bunch of data. It's not all the data that would be important, but I think it will help give you a feel of some of these issues. And then we're going to kind of compare and contrast the U.S. to some of the European countries, especially in some cases other countries as well. So what is it about our healthcare system? What are the facts that we could look at? First, it's hugely expensive. We spend a lot of money on healthcare. You can see the numbers here, $3.5 trillion in 2017. We've tried to capture the latest data that I could get available, but this is clearly representative. Almost 18% of GDP, and it's almost 1/4 of all federal spending, and it's expected to double in the next decade as the baby boomers retire, as Medicare will increasingly get larger. Now, this overall spending, it's not just government. It's a combination of private employer-based insurance as well as government, Medicare, Medicaid, and children's health insurance program spending. And as I mentioned earlier, employer-provided insurance is not a taxable form of compensation, which means that there's little consumer incentive to reduce costs with third-party payment. You have an incentive to get as much health care as you can, because effectively, let's say you're in there's not a 50% tax bracket, but let's just say there were. If you're in the 50% tax bracket, every dollar of additional spending your employer on your health care is effectively $2 for you. So that's kind of why there's, and once you do this third-party payment, you've got that fixed payment, and you want to get as much of that as you can because you've effectively paid for that service. The Affordable Care Act, also known as Obamacare, had a number of features. It set minimum essential coverage, mandated insurance purchase. That was a very important part. Prohibited differential pricing for pre-existing conditions, and incentive states to expand Medicaid. Excuse me. So I'm going to go ahead and build it. In this case, this differential pricing for pre-existing conditions, what that meant is that you couldn't pool risk accordingly. So if you're a young driver, you're going to pay a higher price than I would. What Obamacare effectively did was saying, hey, we're going to average everybody out. If you're a sicker person, you shouldn't have to pay more than a healthier person. Effectively, that's what happens with a pre-existing condition. So that's different from traditional insurance. Now, we did see that there was the employer mandate that companies that had greater than 50 full-time equivalent workers, that worked at least 30 hours a week would have to provide insurance or pay a penalty for not providing health care to their employees. That had the predictable, and all economists were pretty much unanimous in this. This is going to lead to few companies that are on the edge of being at 50 employees would make sure they stayed under. Further, we said that you'll find a number of employees that will be denied more hours now. If they were going to get 34, now they're going to be getting, say, 26 to 29 or something, because if they were to get to 30 hours a week, then we have to pay health care. Further, I didn't cover it here, but this is well known as well. Health care as a cost. Let's say that you have a janitor in your company making $30,000 a year, and you have some professional making $100,000 a year. And let's say that healthcare costs are $10,000 per individual. That would be equal to 1/3 of the cost for the janitor. That if they've now got to provide this healthcare cost and they didn't have it before, you're going to raise the cost of the janitor by 1/3. Whereas your highly skilled worker in your firm that's making $100,000, that same $10,000 would apply. You're only going to increase the cost of that worker by 10%, whereas the low-skilled worker's costs will be increased by 30%. What this had the effect of was once again shifting more jobs towards more professional jobs, more capital-intensive jobs, and harming those with the least skills, because the fixed cost of the healthcare was a very large part of their overall salary. It made them relatively more expensive. So we saw a lot of employees lose their coverage because they couldn't, or lose their hours, excuse me. In some cases, they lost their coverage because the minimum essential coverage, there were some very cheap, very minimalist plans that were outlawed under Obamacare. The people that were supporting the Affordable Care Act called them, I think, MIC plans, little McDonald's kind of plans, and they derived them because they didn't provide much insurance capability. But hey, a little was better than none, which is what eventually happened to some of these employees. Now, the Obamacare, of course, then, okay, well, if they lose their job, we'll give them subsidies to get into the plan. We'll expand Medicaid, and they can get into Medicaid. So we did see a lot of the insurance numbers get cut in half effectively, but they did also have high deductibles. Doesn't mean just because they had insurance did not mean they were actually going into a doctor, because they may not have been able to afford the deductibles, the copays, and all that. And so it wasn't, again, you can't overcome the scarcity aspect just by making this available to all by a mandatory aspect. One of the things, the mandated insurance purchase, which has now been overturned in the Trump administration and legally, was that the goal was try to force young people who are known to be healthier to get into the system, because they wouldn't cost the system as much, and they could help pay more towards older people who are bankrupting the system. So that was kind of the idea, is force more young people in to help pay for old people. And we also saw, and this was predictable as well, the increased regulatory burden led to a lot of individual family practices, individual doctors' practices closing, and those physicians joining the healthcare practice at hospitals. We went from 26% of physicians in hospitals in 2012 to 42% by 2016. That was very predictable because of the regulatory burden of Obamacare. And when they did go, that jumped the costs. Those same doctors, the services they provide in the private practice were significantly cheaper. One study said 14% cheaper than when they were acquired by the hospital. And sadly, but not surprisingly, now that we've seen this consolidation where there's so many large mega hospital firms, the very same progressives that kind of were pushing Obamacare, which led to this result, now use that as an argument why we have to have a single payer system. After driving that consolidation and creating effectively all these oligopolies, now that means we've got to go whole hog. You may be in favor of that, maybe not, but that is kind of the result of, for sure, what happened. We do have what's called a fee-for-service model, where a physician is paid according to the number of services he or she provides. but that incentivizes more care, not necessarily better care. That's some of the facts of the system. Now let's just go through some data real quick. You can see the growth of healthcare over time. Quite significant over a long period of time, but you can clearly make the case we've got a lot better healthcare. You'd rather get almost any, I'd be hard pressed to think of a disease or sickness you would rather have had in 1960 than you'd like to have today. We've got some amazing medical technologies that help us solve problems today. Interestingly, even though it's still going up, there has been a relative flattening of the curve this last decade or so. You see it's still rising, except for the very last few years. But given the increasing number of baby boomers, that's actually a good thing. This next chart just shows you where we get our healthcare coverage. In the United States, we have over 91% of the population that has some form of insurance, but that still leaves quite a large amount that are uninsured. Most people get insurance through their employer, and then government provides a number of the other programs, non-group. You can have private insurance if you're own your own small business or something. You can get individual insurance and so forth. So that's kind of the state of the U.S. population. I wanted to show this to you. This is a quote from Dean Baker. He's a pretty famous progressive economist who just noted, it's a long quote, but go ahead and read this here. I'll give you some comment after I get a chance to read it. And the point of this economist quote, even though he's in favor of single payers, there's a lot of difficulty. We got to really think. We're not going to be able to, in other words, just wave a magic wand. And again, he's in favor of this. And he thinks it will reduce costs because he thinks there's all these efficiencies to get out of it. But to suggest that somehow the United States spends 18% of GDP roughly on healthcare, and if we do what Europe does, we're just going to go down to their 8 or 10% of GDP instantly. We're going to have all the savings. It's just kind of naive, shall we say. That's kind of what he is making that point, which is absolutely true. There are a lot of what we would call in public choice economics. There are incentives that will fight against costs in both directions, whether you want to go to more free market and whatever the status quo is going to have antibodies be created, no pun intended when we talk about healthcare, to prevent you from going either direction in favor of more market forces or less market forces, because the status quo, somebody's benefiting by it. As the bottom quote says, inefficiencies and waste abound, but one person's inefficiency is another person's income. Okay, let's go through the socialist system, and we're going to compare and contrast some of the data from the U.S., but first let's just kind of look at their system. For the most part, what we're talking about is a universal single payer, kind of like our Medicaid, where there's some sort of government minimal level of care. You can have private insurance, private industry, private providers, as well as, it depends on the particular country. But you've got these analogous things. Patients are going to either pay money to the insurance companies or pay taxes to the government, and they're going to get, and those insurance companies or the government, in some cases a combination, will pay for treatment. But the government's going to make sure that there's some guaranteed minimum. And so these are just representative countries that have that system. Here's a kind of one of the genesis of this we need to kind of think about. One of the criticisms of the United States is, look, in the United States, we spend way more money, than anybody else, and yet we get very little to show for it. And whether it's fair or not, kind of the metric that people use is life expectancy. If we had as good a healthcare as these other countries, we would have a higher life expectancy. Surely life expectancy is one of those key variables. And you can see, look where the United States is. We are much lower than many of these other countries. However, Scott Atlas of the Hoover Institution has done some analysis to show if you just adjust the data for two factors, and I'll tell you what those are in just a minute, the United States goes right up to the top of life expectancy. Those two factors are, if you just weed out all these cases, people that die from suicide and people that are involved in high-speed collisions in motor vehicles. If those two factors are taken out, because the United States, sadly enough, has more of both of those. We have higher rates of suicide than Europe, and we also have many, especially young people, that just go out and drive crazy. All these high-speed motorbikes, superbikes, and everything else. Now the former, the suicide, you can make the case that might be a part of the healthcare system because it's mental health, after all, that might be able to preclude that. But the collision, not much you can do for that. And here's a case in point for that. I had to smile at this one. I read about it about 3 or 4 years ago when it came out. Hector Frere, this is his mugshot. You can find it too online. He was busted for going 208 miles per hour in his Mustang in Oklahoma City on the turnpike. Apparently they saw him doing like 85 or something in the 70 on the turnpike. The police started chasing him. He said, I'm going to outrun him. And they clocked him at one point doing 178 and another point at 208. And they finally got him and he turned it out. I did see that this young man was involved in one of the local racing clubs. So I thought that was interesting too. But 208 miles per hour in a 2011 Mustang. Now, whatever the reason, now, he didn't get killed, by the way, and he didn't kill anybody else, praise God. But what if he would have gotten that, that would not have been a failure of our healthcare system. Maybe our educational system, but not our healthcare system. And we in the United States have way more of these kids doing these crazy things than anybody else. Okay, let's look at some more data on this. This is a very interesting chart when you take a look at this. You can look at the United States, UK, and all these other countries, Nordic countries as well, and look at where their spending is. The latest data we had was from 2015. And you see that the United States, what's significantly different is we have a lot more private spending towards healthcare. That is reflective of the fact that we are primarily an employer-provided healthcare system in the United States. But notice here, the United States actually has less out-of-pocket expenses than any of these other countries that we're comparing to. So it's not clear at all that the United States system is more expensive to the individual, right? It is very expensive for the collective, but not necessarily the individual. And that may explain why we spend so much, is because there's more of an incentive from an efficiency standpoint for us to consume when we pay less out of pocket than do some of these other countries. And that might be a model for us. There is the one wrinkle this does not show is the United States, as I mentioned earlier, has a little over 91% of the public has insurance in some cases, whereas these other countries are going to have universal coverage. Those countries, the data that we saw is between 97 and 100% kind of coverage, where we're only like a little over 91%. So, but nevertheless, this is still overall spending in the countries. That's interesting. The biggest factors are we have a lot more private insurance, but we actually spend less out of pocket for those that do have their healthcare spending. Here's another figure on that out of pocket health and spending. The United States is right at the top, except for Switzerland, who's almost double everybody else. But even that seems to me to be a fairly reasonable number per capita. I mean, to say that you would should expect to be able to spend that's less than $100 a month per person that you should prepare as a budget item. That seems to be a reasonable, on average, number in the United States. Obviously, if you're young and healthy, you'd expect it to be a lot less than that. But if you're older, you're going to have a higher number than that. But it's still reasonable for those kind of numbers. Another aspect that we are constantly told, if you look at the chart on the right, this goes back to the life expectancy argument. The United States spends so much money, and yet we have a lot more deaths of infant mortality than others. And you can see the breakdown between neonatal deaths as well as postnatal deaths as well, the days that they have deaths in either category. And we're quite a bit higher than others. However, beyond the surface level view, when you start taking a closer look at it, what you'll find is that in the United States, contra, and Canada does virtually the same thing, and they're number 2 right behind us. If you're born alive in the United States, it's a live birth, whereas in some of these European countries, it's actually you have to be alive for a day or some time period, maybe 2 days. And what that does is that takes care of all the babies that were sick when they were born, and so that doesn't factor into their infant mortality numbers, such that these numbers that are often shown why the U.S. looks worse are apples to oranges, because we take heroic measures to save premature babies and things like that they would not even count as a live birth. And so once again, this is not necessarily indicative that the U.S. system is worse. In fact, in many cases, you would make the claim that the U.S. system is better because we go to heroic efforts for premature babies and so forth that Europeans would not. Here's another chart. I'll let you look at this for just a second. You see these different categories for wait times, and when you look at the data, the U.S. is doing really, really well compared to most countries. France is a little bit better in the red and yellow category, for instance, and Germany likewise. But overall, the United States, you can get to a doctor a lot quicker. You can get access to health care in our system faster than these other countries, especially notice over on the right-hand side, those that have the universal systems. There's a lot longer delays, especially those delays for to get into a specialist or to get to this elective or non-emergency surgery. And another factor is you start looking at kind of the technologies that are being used. The United States leads the world in MRI machines, you see fairly significantly compared to some of these other nations. Also, as I've got over in the left-hand bullet, the PET scanners and the CT scanners, which are very advanced techniques, especially the PET, which captures disease at the cellular level, cancers, heart disease, these kinds of things that you just don't have in many of the, to the degree per capita, the other nations. And the bottom line is, obviously, when you have access to this better medical technology, you're going to be able to diagnose potential health conditions much quicker, leading to a higher probability of living through that effort. And this is reflected in the fact that we get a lot of medical tourism. A lot of people come to the United States to get access to the U.S. healthcare. We had the Italian PM fly in for heart surgery that's noted on the bottom one. A few years ago, one of the Saudi princes came in to get his cancer treated in the United States. The reality is, if you're going to get cancer anywhere in the world, you want to be treated in the United States if you possibly can. And so that's kind of a result of the superior nature of the care that is available. And in most cases, those arguing for it will acknowledge those good things, where they say, well, it's just not fair that some people have access to that, whereas so many in America don't have access to any health care at all. But they wouldn't necessarily deny the superior nature of health care once you have insurance. Got a note, I just think it's important because it illustrates kind of from an economic point of view. Competitive forces actually really do a lot of work, and not just for the U.S. There's a story of an Indian eye clinic where they really just streamlined their processes to almost have an assembly line for cataract surgery in India, where many people were going blind. And what they did after they first did the streamlined processes, and even they allow patients to come in for free if they don't have any money to do this cataract process. But they also created their own cataract lenses and were able to drive down the costs from $70 to $2. The operation and 1 month of medication, $16. So that means that you have a lot of these poor Indians are able to afford it. And actually, the complication rate is 1/2 that of the United Kingdom's National Health Service. Actually, their assembly line process really allows them to keep sterilized these kind of procedures in a lot faster ways. You don't have a doctor going from one room to another, potentially getting contaminated along the way, all these things. And the competitive forces, the things that they've done with their lenses, are now being sold in 120 countries. So that's just kind of an interesting, it's a success story. We love to see it. And that shows that people can go, and people do go to get their medical tourism. There are a number of Americans that will go down to Mexico, for instance, just because of the cost. Even though there may be superior healthcare in the United States, it can be done cheaper in Mexico, and it can be in some cases for some treatments, as well as down in the Bahamas and other kind of countries like that. Okay, here's another chart again, more data. Seniors who waited at least 4 weeks to see a specialist during the past 2 years. Wow, look where the United States is, and look where those red countries, where most of those are your socialized medicine kind of countries in the Nordic, UK countries as well. So again, we get the single payer systems are not necessarily going to be better if you do get sick. If you do get sick, you do have coverage. You're guaranteed coverage. But you're not guaranteed to get coverage in any specific period of time. Again, you can't overcome the law of scarcity. There will be rationing, and if you do not ration by price, you will ration by wait time and something else. So that all weighs in there as well. And then there's other aspects of this. In the United States, most innovative drugs are sold here. We fund 44% of the world's medical research and development. 75% of the global venture capital that's invested towards healthcare industries, and we hold the intellectual property rights for most new medicines. So most of the ongoing initiatives and discoveries are done here in America for healthcare. So I've tried to paint a fairly broad view of some of the facts, as well as some ways to think about some of the questions that are out there, and tie it to the book that we've been reading with Conflict of Visions. Think about how rights are and where they go. Those are up for you to decide and kind of how you think about it. It gave you a little bit of a feel for the biblical way you want to think about your neighbor, and the fact that we do have a responsibility towards others, but that responsibility biblically seems to be one more of mercy rather than justice. Here's what we can conclude. Yeah, U.S. healthcare is very expensive, but it's arguably the best in the world. If you get cancer, you want to be getting cancer and treated in the United States. That doesn't mean there's not a lot of room for improvement. And in fact, in many cases, we have way too little competition, and we could go more. I'm not going to take the time today, but if you want, I can give you some examples of the lack of competition, even in the healthcare market. And I'm in favor as an economist of getting more in that direction to try to improve our system, because the basic problem of our system is not the healthcare per se, it's just the expensive nature of it. Can we drive down costs, and what can we do to do that? A former colleague of mine, Bruce Linster, used to say, if the problem were easy, it would have been solved a long time ago. It really is. And that, I tried to show you arguments from someone like Bruce Linster from several years ago, Dean Baker. Sorry for my phone ringing in the background. The reality is you're going to have these expensive kind of problems because healthcare is a scarce resource regardless of who owns it. You're not going to have a utopia even when you get a single payer system. You can't think about just, hey, look at this and you're going to automatically fix everything. And most of the very intelligent progressives that are advocating realize this is a tough problem. So I think about ways to bring it down, and I can think of ideas on focusing on competition and incentives. And I would also just remind you of the first do no harm. The Hippocratic Oath might be equally applicable to healthcare policy as it is to healthcare practice. And the unintended consequences of the Affordable Care Act ought to give us pause. Most of the economists, so as an example, we saw a lot of underemployment in the wake of the Affordable Care Act, as workers often had to take 2 jobs because their hours were cut. This was completely predictable. And at the time, economists like myself would say, not just me, I mean almost any economist would say this, look, if you have a social goal of providing more coverage, you don't want to do it through an employer mandate, but if we believe that socially we ought to do it, why would you just make that company? What you've done is price that worker out of the job. And that's one of the reasons we saw slower recovery, especially for those that are at the lower skill level, because they became relatively more expensive if you were in a larger company that had more than 50 employees. So that's one of the things we ought to think about. We ought to be thinking about reforms that actually increase competition and alignment of incentives. Again, just trying to paint a broad scope way to think about this because healthcare, even though I'm not a healthcare economist and certainly not a healthcare practitioner, but some of the data and some of the economic thoughts we can think about help us at least have a way to think about it. And I hope you'll think about it. At least at this point, you ought to see that maybe just like there's truly no free market system and just no truly socialist system in the world, what we see in the healthcare policies is kind of a mix in public and private everywhere in the world. It's just kind of the mix. We see pretty much, hey, we've got 90% and over 90% of the coverage in the United States. Could we have more? What's the way to get there? What could that look like? Is single payer the best way? Is it the only way? Are there other ways? These are all kinds of questions that we need to dig a little bit deeper in how we want to think about it.